Before I discuss examples of our studies to promote cancer prevention and control using surveillance data, I would like to take just a minute to talk about the American Cancer Society. Okay, the mission of the American Cancer Society is to end the cancer, as you know, is for everyone with a mission of to improve the lives of people with cancer and their families through advocacy, research, and patient support to ensure everyone has an opportunity to prevent, detect, treat, and survive cancer. And the American Cancer Society is unique among non-government, non-profit organizations in having an intramural and extramural research department where I and Dr. Michi belongs, and it has an advocacy arm known as American Cancer Society Cancer Action Network, and also it has a patient support or a cancer control arm for an integrated approach to combating cancer. So we are the largest private and non-profit funder of cancer research with over 430 million in active grants currently, and we have advocacy presence at every level of government, federal, and in all 56 states, the District of Columbia, Puerto Rico, and Guam. And we do also provide direct patient support in prevention, screening, lodging, transportation to and from cancer centers, and navigation, among other services. So back to my main topic, using surveillance data to promote cancer prevention and control. In the US, in our department, we approach two ways. One is educational publication, which are really SHS flagship publications, as we call them, facts and figures, and they provide a concise summary of the most widely used population-based cancer statistics, and also the estimated number of new cancer cases and deaths in the current year, which are unique for these publications. And the second approach is, of course, to do research. We update and publish 8 facts and figures on regular basis. Cancer facts and figures, which is we call the Blue Book. We have been publishing it annually since 1951, and the other 7 publications supplement the content of cancer facts and figures, and are published, updated and published every 2 to 5 years based on the availability of data. And each edition of cancer facts and figures are accompanied by a more technical report published in the CA, a Cancer Journal for Clinicians, except the CPED, the cancer CPED, which is the Cancer Prevention and Early Detection Facts and Figures, which is published in CBP, Cancer Epidemiology, Biomarkers, and Prevention. Each year, we also update and publish the Cancer Statistics Center, which is an interactive website which provides the cancer occurrence data and from cancer facts and figures, specifically from the Blue Book and also major risk factor and preventive measures and screening from the cancer prevention and early detection factor and figures. Facts and figures in the companion statistics article are widely used across the cancer community as staff and volunteers, cancer control advocates, students, educators, researchers, and policymakers. And for example, our main cancer facts and figures, which we call the Blue Book, receives about 13,000 unique page view per month. And the cancer article is among the most widely cited articles in the scientific literature. For example, the 2019 Cancer 6 article was, I think, cited more than 10,000 times within 2 years after its publication. And the publications also received global media coverage. Now on to our research. As I said earlier, the American Cancer Society is unique in having the research department, the advocacy arm, and patient support or cancer control. So our team, the Surveillance and Health Equities Science, works closely with the staff in patient support and the American Cancer Society Action Network, and other teams, of course, in the discovery pillar or in the research department, to identify and address research gaps for evidence-based decision making by use of surveillance data. And these are some of the surveillance database that we use for our research. And as you can see, almost all of the database are publicly available, except the National Cancer Database, which is privately owned by the American College of Surgeons. So I'm gonna provide or discuss example of our research to actions in the following three broad areas: the Affordable Care Act, National Cancer Control Roundtable, and emerging cancer trends in young adults. As we all know, the United States is the only really high income countries in the world without universal health coverage. Nearly 47 million individuals under age 65 years, representing about 18% of the population, which are shaded in red, were uninsured in 2007, before the implementation of the Affordable Care Act. Therefore, healthcare reform to expand access to care was a major issue during the 2000 presidential campaign. President Obama embraced a larger government role for expanding healthcare, while the late Senator John McCain favored free markets. And in the heat of this, the American Cancer Society was heavily involved in the healthcare reform campaign, and it purchased TV ads to amplify the challenge of uninsured and underinsured cancer patients. And during the heat of the campaign, we published really a more important paper showing a striking survival disparity between privately insured and uninsured or Medicaid insured patients with colorectal cancer. Specifically, the survival for stage 1 uninsured patients, represented by the third dotted red line, was worse than survival for stage 2 privately insured patients, shown in the solid blue line. And this finding was used by American Cancer Society, the American Cancer Society Cancer Action Network, and other civic societies in advocating the passage of the Affordable Care Act in 2010. As most of you know, the law had many provisions. Early provision of the law included dependent coverage expansion that allowed young adults to be covered in their parents' insurance until they turn 26 years old, and elimination of cost sharing for preventive services. But the major provision of the law was implemented in 2014, including the expansion of Medicaid to lower income population, and also establishment of health insurance marketplace for middle income adults with subsidies. So Since the passage of the Affordable Care Act, our group has published quite a few articles to show the positive effects of the law on improving access to care and also cancer outcomes. But in the interest of time, I'll just only discuss one or two studies as example of our work related to dependent coverage expansion and Medicaid expansion. As an example of our studies on the effect of dependent coverage expansion, which was implemented in 2010, we examined changes in proportion of early stage cervical cancer and changes in respect of fertility sparing treatment for women before and after the Affordable Care Act or the implementation of dependent coverage expansion in age groups 21 to 25 years who are eligible for dependent coverage expansion versus in those age 26 to 34 who are not eligible for that specific provision using the National Cancer Database. And after the Affordable Care Act, the proportion of early stage diagnosis and fertility sparing treatment increased in women aged 21 to 25 years, shown in blue lines, but not in those women aged 26 to 34 who were not eligible for dependent coverage expansion. And this study was the first to report on the positive effects of the Affordable Care Act on cancer outcomes, and it was widely covered in major media outlets, including the New York Times. As example of our studies on assessing the effects of Medicaid expansion, which was implemented in 2014 in a paper published in JSO in 2017, we examined changes in uninsured rate and early stage diagnosis before and after the implementation of the Affordable Care Act by income in the non-expansion state compared to expansion state. Following the Affordable Care Act, uninsured rate among cancer patients declined in both Medicaid expansion and non-expansion states. The Medicaid expansion states are represented by the blue line, and the decline in the Medicaid expansion state was steeper. And the increase in Medicaid expansion state was largely due to increase in Medicaid insurance, whereas in Medicaid non-expansion state, the increase was largely due to the expansion, the marketplace exchange, which is because of subsidy in private insurance. We expanded this nationwide data analysis to state level by my colleague, Dr. Shusong Han, and we found a striking state variation in reduction of uninsured rates in neighboring expansion and non-expansion states. Kentucky, which is expansion states at that time, Tennessee non-expansion states, before the implementation of the Affordable Care Act, uninsured rate was high in both states, about close to 10%. But after the expansion, uninsured rate in Kentucky dropped to almost 2%, but it remained unchanged in Tennessee. So we found similar contrasting differences in Arkansas expansion states, Mississippi non-expansion states, and in Colorado expansion states and Utah non-expansion states, and in Oregon expansion states and Idaho non-expansion states. We also found that the disparity in uninsured rate reduced by area level poverty using here census tract and eliminated by rural urbanity in the expansion states, but not in non-expansion states. We also found a small shift to early stage diagnosis for cancers that could be detected early through screening or early symptoms in the Medicaid expansion states, which are shown in yellow bars. And it was for a small shift in early stage diagnosis for colorectal, lung, female breast, and melanoma. More recently, as data matured, we looked at also the association of Medicaid expansion with survival using the North American Association of Central Cancer Registry, which combines incidence data from SEER and NPCR in age 18 to 62 years old patients. So we found that the improvement in survival was greater in Medicaid expansion states compared to non-expansion states. So 2-year survival before and after the expansion of Medicaid increased from 80.6 to 80.2 in expansion states versus from 78.7 to 80% in non-expansion states, with a net increase of 0.44 in expansion states, after accounting for differences in demographic factors. We also, the gain in 2-year overall survival in the expansion states was evident in all socio-demographic factors, whether you look at biodiversity, poverty, or metro and non-metro areas, except for Hispanics, which we didn't see a net gain in the expansion state. In summary, the Affordable Care Act has led to increased health insurance coverage, shift to early stage diagnosis, improved cancer survival, reduced health disparity in expansion states, but at the same time, increased health disparity between expansion and non-expansion states. So our findings have been used in amicus brief in support of the Affordable Care Act, including in Supreme Court. Now on to my second example, the National Cancer Control Roundtable. So the American Cancer Society over the past 2 decades has established 6 National Cancer Control Roundtables, which are a national coalition of public, private, and voluntary organizations to reduce disparity and accelerate progress against cancer through strategic partnership. And many of these roundtables have specific goals. For example, the colorectal cancer roundtable has a goal of 80% colorectal cancer screening in every community. So we have published quite a few articles to support the goals and aims of the national roundtables. But in the interest of time, I will just only talk about the where can colorectal cancer screening intervention have the most impact on mortality, on colorectal cancer mortality. So in a paper published in CEBP, I believe in 2015, we published, we did a cluster analysis of colorectal cancer mortality by county, and we found 3 hotspot areas that involve 12 southern states and also some midwestern states. And rates were, especially in Mississippi, 40% higher than the rest of the United States. And this areas, this high colorectal cancer mortality areas were characterized by high poverty rates, low screening rates, and also high obesity, high prevalence of obesity and smoking. So this finding has catalyzed for community action to expand colorectal cancer screening services in most of the states where we detected the hotspots. For example, the Carolina Carolina Cancer Screening Initiative was founded in 2016 to address the regional colorectal cancer screening disparities in North Carolina based on the hotspot paper. The American Cancer Society Cancer Action Network also used this data to persuade lawmakers from southern states to co-sponsor and pass the Removing Barriers to Colorectal Cancer Screening Act of 2020, which eliminated cost sharing for removal of polyps during routine colonoscopy for medical enrollment. Now to my last broad area, which is emerging cancer trends in young adults. So you may ask, why study cancer trends in young adults? Because they reflect recent changes in the prevalence of exposures during early life or young adulthood, and also they foreshadow future disease burden. A classical example would be the trends in lung cancer rates, here by which a paper that we published in 2008 in JNSI. So the decline in cancer death rates among US men began earlier in younger age group, in 1960s and in 1970s, under 50. But in all those men older than 70, 75, really rates didn't begin to decrease until in 1990s. So the decline in younger age reflects the rapid in the lung cancer rates in younger age group reflects the rapid decline in initiation of cigarette smoking in boys, shown in dark line. Now, in the last also 20 years, in the past 15 to 20 years, we have been also really specifically looking at emerging trends in young onset colorectal cancer, led by my colleague Rebecca Siegel. But the most influential paper was the one we published in JNSAI in 2017, where we looked at the trend by Buzz cohort using age-grade cohort model. So this slide shows the age-specific colorectal cancer incidence rates from 1973 to 74, 2013 by 10 age group before age 50 and by 5-year age group after age 50. As you can see, incidence rates in age under 50 increase while rates under age 55 continue to decline. You see a similar pattern for rectal cancer, rates increasing under age 50, in this case even 55, but declining in the older age group. But if you closely look at the younger age group, the increase in incidence began earlier in younger age group. In 80s, in mid-80s, in age 29, in close to in 1990s, in age 39, and in late 1990s, in 40 to 49. You see a similar pattern for rectal cancer. So rates are increasing really 10 years later. That means as this younger cohorts with high risk of colorectal cancer carry their risk as they are getting older. Then we did also calculated the incidence rates ratio by the score. So if you look at the incidence rates shown in orange is for rectal cancer, and the blue is for colon cancer. And we are showing here the incidence ratio by Buzz score using the 950 Buzz score as a reference. So incidence rates continued to decline in subsequent Buzz quarters until in 1950. But then rates increased in those born after the 1950s. So the incidence rate for those men and women born in 1990s, that about a fourfold higher incidence rates and more than a twofold higher colon cancer rates compared to the risk of rectal and colon cancer born in 1950s. So we extended this paper to about 30 cancer sites, and we, in a paper published in Lancet Publications, and we found that rates were increasing in 8 of the 30 cancer types, 6 of which were obesity-related cancer, including endometrial, gallbladder, and adenocarcinoma of the esophagus. So the finding on the early onset cancer has been a catalyst for ACS and the U.S. Preventive Service Task Force to lower the recommended age to begin colorectal cancer screening for average risk person from 50 years to 45 years old. And also there have been our findings, in addition to findings from other groups on young onset colorectal cancer, have been a foundation for several large-scale etiologic studies on early onset cancers, including the 2020 provocative questions. In conclusion, I hope I have demonstrated to you the value of surveillance research, in this case, descriptive studies to promote cancer prevention and control. And this is a discipline not commonly taught in graduate schools. And also, I have demonstrated the importance of strong collaborations with advocacy organizations, cancer control departments, and lawmakers to translate research findings to action.